Thanks to the SOHO Organizing Committee for the chance to present some of the work that we've been doing in the past few years, and thanks in particular to Alan for that gracious introduction. It's always a privilege to be introduced by one of your heroes and by somebody you admire, so it's really a privilege. So what I thought I'd do today is give a little bit of a perspective on how we think about leukemia and how we're using molecular studies to not only understand why patients get leukemia, but also using those studies to understand if we can develop better therapeutic approaches, because as we know, we're in desperate need of better approaches. And yes, that is a picture of me showing our former vice president chip sequencing data from one of our mouse models of AML. So the fundamental challenge that we have taken on as a field, and in my own laboratory and many others, as Dr. Burnett just articulated, is that AML is a very heterogeneous clinical entity. And I think we all take that for granted, I think, in this room. But for many of our colleagues who, for example, study epithelial tumors, where when they do gene expression profiling and there are only 2 to 5 distinct subtypes and the incidence of the disease is significantly higher, they're always able to assign or test specific therapeutic ideas in large groups. And we have the challenge of a relatively rare disease, relatively rare, and a relatively large number of subgroups. And this is just using gene expression profiling. You could do the same thing with epigenetic profiling. You get this other groups, which may or may not be the same as gene expression groups. So there may be as many as 20 to 25 distinct subtypes of acute myeloid leukemia. And I would argue that one of the reasons why it's hard to develop drugs in this disease is to ask one drug to work in a small 30-patient cohort across 25 different subtypes is a recipe doomed for lack of success. So that's the glass half empty perspective. The glass half full perspective, and where I think we're the envy of our colleagues in other oncologic contexts, is that this tremendous biologic and clinical heterogeneity comes from a relatively simple genetic set of characters. And if you think about it, that is left based on 2 observations. And this is data from this slide from TCGA, but there are many studies done by many in the field that show the same thing. The first observation is that the typical AML patient has between 3 to 10 coding mutations in their entire cancer genome. Think about melanoma, where you have UV-induced mutagenesis and thousands of coding mutations, and the statistical gyrations you have to go through to figure out what are the drivers versus what are the passengers. We're in the enviable position that the majority of the genes that are mutated have a clear, functionally validated, or likely role in pathogenesis. The other thing I think that's important is that those 3 to 10 mutations occur in a relatively small number of genes. Is it 40 genes? Is it 60 genes? It depends on where you draw the line. But the answer is it's not thousands. So you can almost think of AML as like a series of plays or movies, where in each of them you have a slightly different cast of actors and actresses, but they come from the same pool of actors and actresses. And each story that you tell is different, but it uses the same parts that are mixed and matched differently. And so the question that my lab has become interested in then is understanding how does each story for each subtype of leukemia develop? And how does that road differ from the other roads? And can we understand the molecular features of that? And if we take a step back even more fundamentally, I think we have to ask ourselves not only how do you get 25 different subtypes, but what is the journey that a cell takes from being a normal hematopoietic stem and progenitor cell to becoming a fully transformed leukemia cell. And Alan gave reference to clonal evolution. I'll remind you that many groups have now shown that walking around, for example, right out on the street or in the Galleria, you'll find countless people that have mutant hematopoietic cells that are clonally expanding and evolving over time. There are millions of people in the United States that have mutations in genes like DNMT3A and TET2. This is different than the 10,000 people per year or 15,000 that get AML. So that's the conundrum. Why would you have so many people that get the early events, and then the early events are in the exact same gene, often in the exact same spot, but a relatively small number of people that develop AML? So why is there this bottleneck, and what are the unique features about the patients that develop AML? And then the other question, of course, is the road that a cell takes to become AML, all the mutations it acquires throughout its process, the 3 to 10, are all of them still required by the leukemic cell at the time of transformation? Meaning, can we target any mutation, regardless of whether it's acquired early or late, and can we target combinations of mutations? So what I thought I would do today is give you 3 just brief tastes of some of the work that we and others have been doing that can teach us some of the things that we learned. So the first thing I thought I would talk about for a few minutes is clonal hematopoiesis and somatic mutations. This is known to most of us in this room, but I'll remind you that in the past 5 to 6 years, we've now had an explosion of information about this concept of clonal hematopoiesis. In 2012, Lambert Busque and I and our colleagues described an elderly woman that had skewed X inactivation, really building on the work of Fialco and colleagues from the 70s that really defined this field, showed that a subset of these women had somatic mutations in TET2. Ravi Majeti and then John Dick showed that even in transformed patients, you can identify these pre-malignant clones at the time of transformation. They still remain there as almost the soil under which the leukemia evolves and arises as plants. And then Ben Ebert, Elaine Martis, and TCGA, Steve McCarroll, and others have taken large population-based cohorts and shown that this is a common phenomenon. The implications of this are, and I don't want to overestimate, but I really believe this, are immense. It's hard to overestimate their importance. So the first is, imagine for patients that have solid tumors that might have these mutations in their leukemia cells at the time you give them treatment and the implications for that. What about following minimal residual disease? Roland Walter is in the audience, who's been a leader of that. How do you track MRD by mutations? And some of the mutations aren't just in the leukemic cell, but are in the pre-transformed cell, and might be left behind and may actually never be a problem for relapse, or they might be. So we can't just move easily from MRD by flow to MRD by genetics. And most recently, Kevin Walsh, Ben Ebert, and Sek Katharesan, and others have shown that the primary driver for cardiovascular risk in the modern era where patients get aspirin and lipid control are clonal hematopoietic mutations. So this has tremendous implications. And I think for all of us in this room, what we have to remember is that I think this will be the first frontier for effective malignancy prevention. We've had decades of failed studies of vitamin supplementation and lifestyle changes and controversial studies about non-steroidals. Imagine now if you can do those studies but match the right one of those interventions to the right subtype. Hypersupplementing vitamin C in the 5% of patients that have TET2 mutant clonal hematopoiesis. You might be able to take negative studies and turn them positive, and we might be able to intervene in a way we couldn't before. So we've become interested in that idea that perhaps by studying at-risk populations, we can learn things about biology, but also predict outcomes. And so clonal hematopoiesis is an aging phenomenon. The older you get, the more clones and mutations you have. So are the development of epithelial tumors. And we became interested in asking, do mutations in hematopoietic cells occur in solid tumors, and do they affect their biology? Are they selected for by the cancer therapies patients get? Do they affect the response or hematopoietic toxicity for systemic therapies? Is the response to the primary tumor affected? And how do we monitor patients for the subsequent development of hematologic malignancies? And so we were very fortunate because we were able, instead of doing a sequencing experiment, to do a data mining experiment. So Sloan Kettering, about 3 years ago, embarked on systematic tumor normal sequencing of all advanced cancer patients with solid tumors using tumor, FFPE as the tumor, and blood as the germline or matched normal. So we're fortunate to collaborate with Mike Berger and colleagues to ask not what's in the tumor, but not in the normal, but what's in the normal, the blood, and not in the tumor. And Callie Combs, who did this incredible body of work with Amit Zamir, who's now at UNC as a faculty member, took this large cohort of our first 9,000 patients and asked, what's the frequency of mutations in solid tumor patients who have their blood sequenced? And we did detailed manual chart review of 5,700 charts because there is no way we've found using computational approaches to abstract that information. So what did we learn? The first thing we learned is that 25% of all patients who show up to Sloan Kettering with advanced cancer have a somatic mutation in a known pathogenic leukemia driver. And the mutations you get are the ones you'd expect. DNMT3A is the dominant player, TET2, PPM1D, previously described by the field of solid tumors as a mosaic risk mutation. That is wrong. It is a somatic mutation in blood because the only tissues they ever tested for mosaicism were peripheral blood. And many patients have more than one mutation, and we don't yet know if those are in the same or different clones. If you look at the frequency in our cohort, we were able to show that although it's 25% in aggregate, when you get above the age of 70, more people have clonal hematopoiesis than don't. And that is an interesting question. You would say that's quite common. And it's more common than you see in these other studies. And why is that? Is that because these are cancer patients and they're heavily treated, or because we're sequencing to 500x coverage and we can go deeper? The short answer is we're going to collaborate with Ben Ebert and St. Catherine to compare Framingham and Physicians Health Study and this cancer cohort to define that, because we don't know yet if it's more common in cancer or if it's the way that we do our analysis. The other interesting phenomenon, and I was speaking earlier today to Peggy Goodell about this because we share an interest in DNMT3A, is that you can learn something interesting from the variants that you see in patients. On the top, this is the mutational spectra in one gene, DNMT3A, in clonal hematopoiesis. On the bottom, this is the data from Perrier Campbell and Ellie Papamanuel and Hartmut-Donner and colleagues in 1,500 AML patients. And I think it's pretty obvious that the spectrum of mutations in clonal hematopoiesis is much broader. It turns out that this is because we're looking at any variant allele frequency that's 1% or greater. If we restrict this to 10 or 20% or greater, it looks just like AML. So what does that tell you? It tells you that not only is it what gene you get a mutation in, but it's also what spot in what gene gets the mutation, and they have variable fitness advantage. So it's the wrong mutation in the wrong gene at the wrong spot, and maybe with the wrong environmental perturbagens, obesity, inflammation. So we have to think of not just what these mutations do by themselves, but how they interact with the cell and their environment. It also suggested to us that we should focus on the patients that have big clones of 10% or greater. So we next wanted to look at environmental perturbagens and whether they increase the risk of clonal hematopoiesis. And what we were able to find, to our surprise, was that chemotherapy does not increase the risk of clonal hematopoiesis, but radiation does and smoking does. And the radiation includes localized radiation. These are not mantles. These is modern radiation. Thyroid, including radioactive iodine. So local radiation to one spot, probably where there's bone, can allow a clone to evolve over time. What about overall survival? We were able to show that overall survival is impaired, particularly if you have large clones, and the cause of death is progression of the primary tumor. So the majority of these people are not dying of leukemia. They're dying because their primary tumor is actually progressing. And it turns out we thought it's because probably these patients get hematopoietic toxicity because they have an altered hematopoietic compartment. No increase in growth factor transfusion requirement. So if anything, they have less transfusion. So we think that these cells are in crosstalk to the solid tumors and are promoting their expansion over time. But most importantly, these patients are at massively elevated risk for hematologic tumors. So if you look on the right in B at the patients that have 10% clones or greater, their aggregate risk in the first 18 months of a cohort we're going to follow for many years of getting a hematologic malignancy is 3%. So imagine you have a patient, you're going to give adjuvant AC Taxol on a dose-dense regimen and radiation with breast cancer, and they have a 3 to 5% now risk of a secondary hematologic malignancy if they have a clone that's 10% or greater. It might start to actually factor into your calculus about whether to give them adjuvant therapy. We need to be ready for that reality.